You know that feeling when just moving feels like a bit of a chore, or that morning stiffness, it just hangs around.
Yeah, it's really frustrating.
Exactly. And figuring out why your body's doing that, well, that can be tough.
Yeah.
So today, we're diving into one of those puzzles, a condition many people live with, but maybe don't fully grasp. Rheumatoid arthritis, RA.
Right, RA. And look, for many of you listening, this might be something you deal with, or someone you know does.
Mm-hmm.
So our aim here, like always, is to give you a really clear, solid understanding. Cut through the noise,
Get straight to the point.
Yeah, we've gone through some detailed revision notes on rheumatoid arthritis, pulled out the key stuff,
So the mission is to take those notes.
and turn them into something memorable, understandable, covering the basics, the causes, complications. The whole picture, really. Think of this as your focus briefing on RA.
Perfect. Taking that info, making it stick, giving you those aha moments. We'll look at what it is, what might cause it, who gets it.
How it affects the body, what else it could be confused with.
Right. Diagnosis, management, the outlook, and potential problems down the line. Ready to jump in?
Let's do it. So, first things first. What exactly is rheumatoid arthritis?
Okay, yeah. The definition. Let's start there.
Okay, so at its heart, RA is a chronic autoimmune disease.
Chronic autoimmune. Break that down a bit.
Okay, so chronic means it's long-term persistent. Autoimmune means your immune system, your body's defense force, basically gets confused.
Confused how?
It mistakenly attacks the lining of your joints. It's called the synovium.
Oh, okay.
And that attack causes inflammation in the joint.
So the body's kind of fighting itself in the joints?
That's a good way to put it.
Yeah.
And the key things to remember, it's chronic, autoimmune, inflammatory. And it's not just about the joints. It can affect multiple systems.
Right, you mentioned extra-articular manifestations.
Exactly. So while joints are the main focus, the pain, stiffness, swelling, it can pop up elsewhere in the body too.
Doesn't sound minor. How common is it?
Well, estimates suggest around 1% of people globally have RA. And it's significantly more common in women, about a 3-to-1 ratio women to men.
Interesting. The notes also mention seronegative RA. What's that about?
Ah, good point. It's an important distinction. See, about a third of people with RA, well, their blood tests don't show those typical autoantibodies we often look for, like rheumatoid factor or anti-CCP.
So they have RA, but the tests are negative.
Exactly. We call that seronegative RA. It suggests the immune process might be a bit different in those cases compared to seropositive RA, where the antibodies are present. Can make diagnosis a touch trickier sometimes.
Okay, that makes sense. So we know what it is. Now, what about the why? What actually causes RA?
Well, that's the big question, isn't it?
Yeah.
And the honest answer is we don't know the exact single cause. It's not like catching a cold.
More complex.
Much more complex. It seems to be a mix of different factors all interacting.
The notes use that GEI mnemonic, right? Genetic, environmental, immunological.
That's a great way to remember the main players. GEI. So genetics first. Your genes definitely play a role.
How so?
Certain genes can make you more susceptible, more likely to develop RA if other factors align. The HLA-DR4 haplotype is one that often comes up.
So having the gene doesn't guarantee RA?
No, not at all. But it increases the risk, like having a family history might.
Okay, so genes load the gun, maybe. What about E for environmental?
Right. Environment potentially pulls a trigger. Several things here. Smoking is a big one, consistently linked to higher risk and often more severe RA.
Smoking, okay. What else?
Well, there's a list. Things like high birth weight, exposure to silica maybe from certain jobs. Interestingly, abstaining from alcohol has been noted. Obesity, having those rheumatoid factor or anti-CCP antibodies already.
Even before RA develops?
Potentially, yes. And there's ongoing research into whether certain infections could act as triggers in some people. No single culprit identified, though. Oh, and also a slightly higher number of diagnoses seem to happen in winter. Still figuring out why that might be.
Wow, that's quite a range of potential influences. And the I. Immunological.
That brings us back to the core mechanism. The immunological part is that mistaken immune attack we talked about.
The attack on the synovium.
Exactly. For reasons we're still working out, the immune system targets that joint lining. This sets off a whole inflammatory cascade.
Which leads to the damage.
Precisely. The cartilage, the bone. It's the body's own defense system causing the problem in the joints.
So it sounds like maybe someone has the genetic tendency, then they encounter certain environmental things like smoking, and that somehow flips a switch in their immune system, leading to the attack.
That's pretty much the leading idea. A complex interplay. Genes, environment, immune response, all tangled up.
Okay. Let's circle back slightly and focus just on risk factors. We've mentioned some, but let's list them clearly. Who's more likely to get RA?
Right. So number one is that genetic predisposition. Specific genes like HLA-DR4 and DR1 definitely increase risk.
And Jen.
Yes, female gender. Significantly higher risk for women compared to men, that 3-to-1 ratio we mentioned.
And the environmental factors function as direct risks, too.
Absolutely. Smoking is a key one.
Yeah.
Big risk factor for developing RA and for having more severe disease.
And the others?
Yeah, all those things we listed, high birth weight, silica exposure, alcohol abstention, obesity, diabetes, having RF or anti-CCP present, they all add to the risk profile.
Plus the potential infection triggers.
Right, the possibility of infective triggers and that slightly higher onset in winter, all contributing factors.
Got it. So we know who's at risk. Now let's get into the nitty-gritty. What's actually happening inside the joint? The pathophysiology.
Okay, think of it like a multi-step invasion by the immune system. Step one, immune activation. Something kicks the immune system into high gear.
And then?
Then, these activated immune cells infiltrate the joint. They specifically target that synovial lining.
They get inside the joint lining. What happens next?
They start releasing chemicals, pro-inflammatory cytokines. Think of them as alarm signals or messengers that really ramp up the inflammation.
And these cytokines, they cause the damage.
Yes, they're destructive. They directly contribute to the breakdown of cartilage and bone within the joint.
So it's this constant inflammation fueled by these cytokines that leads to the problems people experience.
Exactly that. It's a chronic inflammation cycle. Immune cells arrive, release cytokines, cause damage, attract more immune cells, and it keeps going, leading to those deformities and functional issues over time.
Okay. Now, RA symptoms can overlap with other things, right? Differential diagnosis is important. That Mnemonic was quite something. Go slave, PC flimes.
It is a long one,
Yeah.
but it really drives home how many conditions can look like RA initially. It's crucial to rule these out to get the right diagnosis and treatment.
Makes sense. Should we quickly run through them, why they might be confused with RA?
Yeah, good idea. So gout and osteoarthritis both cause joint pain, right?
Yeah.
But gout is uric acid crystals, OA is wear and tear, different mechanism. SLA is systemic lupus erythematosus, or SLE. Another autoimmune condition can affect joints, but usually hits other organs differently than RA typically does. V is viral arthritis, joint pain after a virus, but it usually clears up, not chronic like RA.
Got it. What about the PC flimes part?
Okay, P is reactive arthritis, joint inflammation triggered by an infection somewhere else, like the gut. C is other connective tissue diseases like scleroderma. F is fibromyalgia, widespread pain, fatigue, but not the same joint inflammation. Li is Lyme disease from ticks. Med is a catch-all for other medical conditions causing joint issues, sarcoidosis, thyroid problems, even some cancers. S covers a few. Seronegative spondyloarthropathies like psoriatic arthritis, polymyalgia rheumatica, which hits bigger joints in older adults, and crucially, septic arthritis. A joint infection, usually just one joint, needs urgent treatment.
Wow. Yeah, definitely need to be thorough with diagnosis. So who actually gets RA in the population? What's the epidemiology? The notes focused on the UK.
Right, UK data. So prevalence, how many people have it, is around 0.8% of adults.
And the gender split.
Definitely more common in women, 2 to 4 times more likely. The specific figures mentioned were at least 1.16% in women versus 0.44% in men.
And when does it usually start? Is there a typical age?
The peak age of onset is usually between 40 and 60. But, and this is important, it really can start at any age, childhood, later life, anytime.
Okay. And new cases each year, the incidence.
Incidence is relatively low. For men in the UK, it's about 1.5 new cases per 10,000 people per year. For women, it's higher, around 3.6 per 10,000 per year.
So not a huge wave of new cases, but a significant number living with it. Okay, let's talk about how it shows up, the clinical features. The notes had that core idea. Morning symmetrical, small joint pain, and swelling with tiredness.
That's a really good summary of the classic presentation. The absolute core symptoms are that joint pain, the swelling, and really noticeable morning stiffness. Stiffness that lasts, more than 30 minutes, often over an hour.
And key features are the symmetry.
Yes, symmetrical involvement is typical. If your right wrist is affected, your left one probably is too. And it often starts in the small joints, particularly hands and feet.
Are there other general symptoms people feel beyond the joints?
Oh, yes. Many people also experience fatigue, sometimes quite profound, like loss of appetite, just feeling generally unwell, that malaise.
And the typical age for symptoms starting?
Usually between 30 and 50, but again, it can vary. On examination, a doctor will find those swollen, painful, stiff joints. worse in the morning, lasting over an hour. You might also see tenosynovitis, tendon inflammation, or bursitis.
And in later stages?
In more advanced RA, you can get characteristic joint deformities. And there's a rare but serious potential issue called atlantoaxial subluxation instability in the upper neck vertebrae that can affect the spinal cord.
You also mentioned it affects other body parts, those extra-articular manifestations, that mnemonic again, respicato nos lucet. Quite a list.
It covers a lot.
Yeah.
It shows how systemic RA can be. So RSPI is respiratory. Think interstitial lung disease, fluid on the lungs, pleural effusions. CO is cardiac, pericarditis, myocarditis, higher cardiovascular disease risk, even valvulitis.
Yeah.
D is dermatological, rheumatoid nodules, often near elbows, leg ulcers, rashes. He is hematological, anemia, low white cells, neutropenia. N is neurological, nerve entrapment like carpal tunnel, that atlantoaxial subluxation, nerve damage, polyneuropathy. O is ophthalmic, eyes, dry eyes, keratoconjunctivitis, silica, scleritis, piscloritis, corneal issues, plus potential medication side effects like cataracts. ST is systemic others, things like thyroid issues, osteoporosis, depression, a large spleen, splenomegaly, higher infection risk. LU is liver, maybe mild enlargement, abnormal enzymes. Key is kidneys. Involvement is rare, but possible, like amyloidosis. And T reminds us of thyroid again.
That is extensive. It really can touch almost any part of the body. So how does someone usually first present? What's the typical story?
The most typical presentation is someone noticing swollen, painful joints in their hands and feet, plus that morning stiffness. And it usually comes on gradually, over weeks or months. The squeeze test, gently squeezing across the knuckles or toes, is often painful.
But it's not always like that.
No. There are other presentations. Some have a really sudden onset, maybe with fever, feeling quite ill systemically. Others might have what's called palindromic rheumatism, episodes of inflammation in one large joint. Then it resolves, then another joint flares up, relapsing, remitting monoarthritis.
And the eye problems you mentioned, are they very common?
They are relatively common, yes.
Yeah.
About 25% of patients experience some ocular manifestations. Dry eyes are frequent, but also the more serious things like scleritis and episcleritis. Definitely something to be aware of.
Okay. So with all these possibilities, how do doctors actually pin down the diagnosis? What investigations are involved? The mnemonic was blimp ACR nice.
Right. Diagnosis is really a combination approach. The clinical picture, lab tests, and imaging. BLIMP covers the initial workup. Bloods are key.
What are you looking for in the bloods?
We check inflammatory markers, CRP and ESR, usually elevated. Then the autoantibodies, rheumatoid factor, RF, and anti-CCP.
How useful are those antibodies?
Well, RF is positive in about 70% of people with RA, but it's not specific. Other conditions can cause it. High levels might suggest more severe disease, though. Anti-CCP is more specific to RA and often predicts a poorer prognosis, unfortunately.
Okay.
We also do routine bloods, full blood count, liver, and kidney function. Then I, for imaging, usually start with x-rays of hands and feet, baseline images to see damage and track changes. Ultrasound can sometimes be used too. It's good for spotting synovitis.
So that's the blimp. What about ACR nice?
Right. So the American College of Rheumatology, ACR, has classification criteria, the 2010 ones. It's a scoring system. You need 6 out of 10 points for a definite RA classification.
How does the scoring work?
It looks at 4 things: joint involvement, how many joints, what size; serology, presence and level of ARF anti-CCP; acute phase reactants, CRP-ESR levels; and duration of symptoms, less or more than 6 weeks. Points are awarded in each category.
So it formalizes the combination of clinical signs and lab tests. And nice.
Yes, the National Institute for Health and Care Excellence in the UK gives guidance. They stress that clinical diagnosis by a specialist is paramount. The criteria help, but the doctor's judgment is key.
What do they recommend specifically?
They highlight using RF and anti-CCP tests. They recommend x-rays of hands and feet for everyone suspected of having RA. They list non-specific tests, like ESR, CRP, and specific ones, RF anti-CCP x-rays, based on clinical findings. And importantly, they advise specialist referral for persistent synovitis, especially in small or multiple joints, and an urgent referral if there's been a delay of over 3 months between symptoms starting and seeking help.
Okay, diagnosis made. What's the plan then? How is RA managed? The mnemonic. DMARD's biologics, no surgery, monitor, diet, refer.
Management is all about controlling symptoms, stopping joint damage, and keeping quality of life high. It's a mix of drugs, non-drug approaches, regular checks, and lifestyle. We often use the DAS-28 score to track disease activity and adjust treatment.
Right. Let's break down the mnemonic DRNs.
Disease-modifying antirheumatic drugs. These are the foundation.
Yeah.
Methotrexate is usually the first choice. Others include sulfasalazine, hydroxychloroquine, leflunomide. Often corticosteroids are used alongside them initially to get inflammation down quickly.
And if those aren't enough, biologics.
Exactly. For more severe RA, or when DRNs haven't worked well, we move to biologic agents. These are more targeted therapies. Common ones are anti-TNF inhibitors, names like adalimumab, etanercept, and infliximab.
There are quite a few.
Yes. And other types too, like abatacept, rituximab, tocilizumab. NICE has guidelines on when to use these generally for severe active RA, and response needs to be monitored using EOR criteria to continue them.
Okay. What about the no surgery part of the mnemonic? That seems a bit counterintuitive.
It means surgery isn't the primary treatment for the RA itself, but orthopedic surgery definitely has a role for specific problems.
Like what?
Uncontrolled pain, really limited movement, deformities, maybe a tendon rupture or nerve compression. Joint replacement is an option, even for younger people if the damage is bad enough. But things like septic arthritis or tendon rupture need urgent surgical referral. Specialist opinion should be sought early for ongoing issues.
Makes sense. And the last bits, monitor, diet, refer.
Regular monitoring is crucial. Specialist review, usually annually, to check disease activity, damage, function, other health issues, complications, and how RA is impacting life.
Diet.
Diet. A Mediterranean diet is often encouraged. Good general health benefits, potentially anti-inflammatory. Complementary therapies might offer some people short-term relief, but shouldn't replace standard treatment.
And refer.
Refer just reinforces those referral guidelines. See a specialist for persistent synovitis, especially if there's been a delay, and urgent referral for suspected septic arthritis or cervical myelopathy.
Definitely sounds like a team effort and an ongoing process. What about the long view, the prognosis?
It really varies a lot, depends on severity, individual factors, but the big message is early diagnosis and effective treatment dramatically improve outcomes. It helps prevent that long-term damage.
Oh, it is chronic.
Yes, it's chronic.
Yep.
Many people manage well, but some will have ongoing issues and progression.
The notes had some poor prognostic features, the RF, anti-CCT, poor early extra-HLA, insidious mnemonic. What do these mean?
These are signs that might suggest a tougher course ahead. Being RF positive, having anti-CCP antibodies, having poor function early on, seeing early X-ray damage, erosions within 2 years, having extra-articular features like nodules,
Okay.
also having the HLA-DR4 gene, and an insidious gradual onset. These can sometimes point towards more aggressive disease.
Any other factors influencing prognosis?
Yeah. Being female, while more likely to get RA, is sometimes linked to a poorer prognosis. And paradoxically, younger age and male gender can sometimes mean more rapid joint damage if they do get it. And of course, persistently high disease activity generally leads to worse outcomes.
And sadly, there's increased mortality risk.
Yes,
Yeah.
unfortunately. People with RA have a higher risk of death, often linked to cardiovascular disease, infections, or vasculitis.
Okay, finally, let's cover the potential complications. The notes took an organ-based approach.
Right. So complications
Yeah.
in the joints, deformities, functional limits
Hmm.
in the bones. Osteoporosis, higher fracture risk.
Heart and lungs.
Heart blood vessels, increased cardiovascular disease risk, pericarditis, myocarditis, vasculitis. Lungs, interstitial lung disease, breathing problems, pleurisy, effusions, fibrosis, nodules.
Eyes, nerves, blood.
Eyes, dry eye syndrome, scleritis, episcleritis, nerves, neuropathy, carpal tunnel syndrome, that atlantoaxial subluxation, blood, anemia, or rarely Felty syndrome, big spleen, low white cells.
And the others.
Amyloidosis is rare. Depression is common. Skin ulcers, orthopedic issues like tendon rupture, and a big one, increased risk of infections, including septic arthritis.
And the treatments themselves can cause issues too.
Yes, that's the downside. Drug-related complications. NSAIDs can cause stomach problems. Steroids and immunosuppressants increase infection risk. Methotrexate can affect the liver. There's debate about a potential small increased malignancy risk with TNF inhibitors. And even low-dose steroids contribute to osteoporosis long-term.
Right. Well, that was definitely a deep dive into rheumatoid arthritis. Just to quickly recap the essentials. It's chronic, autoimmune, attacks the joint lining, causing inflammation, pain, stiffness, swelling.
Caused by a mix of genes and environment, we think.
Diagnosis uses clinical picture, blood tests like RF and anti-CCP, and imaging.
And management is multifaceted. DRMARDs first, biologics if needed, plus non-drug therapies and monitoring.
Prognosis varies, but early treatment is key. And it can cause complications across the body, plus potential drug side effects.
That sums it up well. And hopefully this is giving you, the listener, some real clarity on a complex topic. If you want to dig deeper or revise this further, definitely check out PassTheMSRA.com. Great resource.
Absolutely. And for more general musculoskeletal resources and community support, freemosray.com is another excellent place to visit. Loads of useful info there.
And maybe a final thought to leave you with. Research into autoimmune diseases like RA is moving fast. Our understanding keeps evolving.
Which offers hope, right?
Exactly. Hope for better, earlier diagnosis and more targeted, effective treatments in the future. Improving things for everyone living with RA.